Welcome, everyone, and thank you for joining us today as we reveal the results from our 2024 Medicaid Managed Care Organization Survey. Next slide. I'm Dr. Jennifer Moore and serving as the founding executive director of the Institute for Medicaid Innovation. We're a national 501c3 nonprofit, nonpartisan research, policy, and community power building organization focused on providing innovative solutions that address important clinical research and policy issues in Medicaid through multi-stakeholder engagement. Next slide. For those who are new to IMI, our mission is to improve the lives of Medicaid enrollees through the development, implementation, and diffusion of innovative, evidence-based models of care that promote quality, value, equity, and the engagement of individuals, families, and communities. Our work centers around our strategic priorities on a broad range of topics, including women and gender health and behavioral health. We accomplish our priorities by leading activities such as multi-stakeholder learning collaboratives, research and data analysis like our survey and CDPS risk adjustment model projects, education such as our learning series, quality improvement initiatives, and dissemination and implementation activities. Next slide. As we say at IMI, it's not the statistics that make Medicaid real. It's when you love one of the numbers. As a former Medicaid member myself, I understand how important this program is to individuals, families, and communities. Everyone covered by Medicaid is much more than just a number. That's what we're going to discuss today, to go beyond the numbers and tie the results of our survey findings back to how they affect those who are enrolled in the Medicaid program, along with their caregivers, families, and communities. Next slide. Here's an overview of our program for today. First, we'll hear remarks from our funder of this signature project, the Robert Wood Johnson Foundation. After that, I'll present the key findings from the survey. And lastly, I'll invite our panelists to join me to share the reflections and insights of the findings with an opportunity for audience Q&A. As you think of questions during the presentation or panel reflection, please submit your questions. Our team will be compiling them. Next slide. It is my honor to have Dr. Beth Wickler here with us today to provide opening remarks. Dr. Wickler serves as a senior program officer at the Robert Wood Johnson Foundation within the Transforming Health and Healthcare Systems strategic portfolio. Dr. Wickler, thank you for being here and for your support of this important project.
Thank you, Jennifer, and thank you for inviting me to be here with you all today. The Robert Wood Johnson Foundation is proud to support the Institute for Medicaid Innovation and its Medicaid Managed Care Survey. Like many of you, I'm eager to hear more about the 2024 results and get input from our panelists. As many of you know, the Foundation is dedicated to taking bold leaps to transform health in our lifetime. To get there, we must work to dismantle structural racism and other barriers to health. Through funding, convening, advocacy, and evidence building, we work side by side with communities, practitioners, and institutions like IMI to achieve health equity faster and pave the way together to a future where health is no longer a privilege but a right. Now that the election has been decided, I want to reaffirm that the Robert Wood Johnson Foundation's unwavering commitment to this mission and to our partners. We remain committed to advancing health equity and working together to tear down barriers to health and well-being. This includes bolstering our work around diversity, equity, and inclusion, reproductive justice, and access to affordable health care that treats everyone with dignity. That's why the work of the Institute for Medicaid Innovation is so important. This survey provides comprehensive, evidence-based information to states as they work to strengthen Medicaid programs and better serve enrollees. And it sparks critical conversations about longstanding challenges and emerging opportunities. As we navigate next steps, this survey helps shed light on how we can make positive changes that will help all people thrive. Thank you again for having me here with you and for all of this work, and I'm looking forward to hearing more about the data. Thanks, Jennifer. I'll turn it back to you.
Thank you, Dr. Wickler. And truly, without the support of the Robert Wood Johnson Foundation, this project would not be possible. And this has been a long-standing project, and we appreciate the support. Next slide. Since our beginning 10 years ago, IMI is focused on delivering objective, unbiased data to inform and guide policymaking for the improvement of the Medicaid program and the health of the nation. We've developed a broad portfolio of work addressing critically important issues in Medicaid, like maternal health, the redetermination process post-pandemic, social determinants of health, value-based purchasing, and Medicaid risk adjustment through the CDPS model. The annual Medicaid health plan survey is our flagship project, but it's one of many, some of which we will reference today. Next slide. Our one-of-a-kind survey offers longitudinal findings and trends among Medicaid health plans over the last 8 years. Our understanding of the program has evolved over the years as we also collect information on Medicaid health plan best practices, learn about their partnerships with communities, and analyze the data for current trends. Next slide. When the survey was originally being developed, we received close to 1,000 suggested questions for inclusion. Through a rigorous process of review, pilot testing, and refinement, the survey today is a reflection of the dedication of hundreds of volunteers who believe that the survey had the potential to provide invaluable insight into the Medicaid program. This proved to be incredibly helpful during the pandemic as health plans continued their commitment to completing the annual survey, identifying shining moments and areas where additional support was needed. Today's survey captures information across the 11 domains ranging from high-risk care coordination and pharmacy to behavioral health and child health. For each of these domains, we ask a series of questions to help uncover the progress, challenges, and opportunities health plans are facing. Each question on the survey offers findings that inform and guide Medicaid policy. Next slide. The completed surveys we received represent 36 of the 42 states with Medicaid managed care. The health plans responding to the surveys are representative health plans nationwide and proportionate to the different types of health plans: private nonprofit, private for-profit, and government-owned. Most of the respondents represent single state health plans rather than multi-state, and the size of the health plan is reflective of the national demographics. Next slide. Although we wish that we could share all of the findings during this webinar, the reality is that the survey collects an incredible amount of rich data that is impossible to do today. However, we release all findings from the survey in easy-to-use fact sheets for each of the survey categories. You can find the fact sheets at our newly designed website, and the link is being put in the chat for you now. Before we get started, we want to remind you to submit your questions. Again, we will answer as many as we can later in today's presentation as part of the panel discussion. Next slide. So let's dive in. Behavioral health is always an important topic. As part of the survey, health plans identified a number of ways that state Medicaid agencies could assist in addressing the behavioral health needs of its members. Highest on the list was facilitating an increase in providers who participate in the Medicaid program and supporting behavioral health providers in home and community-based services. Next slide. All health plans reported that the shortage of in-person available behavioral health providers is a crucial issue, particularly for children and adolescents. As you can see from this slide, other key data points that we found that are worth noting include 87% of health plans said that their members' ability to access in-person behavioral health is a challenge. And 87% also indicated that excessive wait times for specialty care has been a barrier. Next slide. Many have looked to telehealth to help address concerns about the shortage of behavioral health professionals. And indeed, coverage for telehealth has increased significantly in recent years, as demonstrated in our survey data. However, as we all know, coverage does not mean access. All health plans reported that they have members who do not have access to broadband at 91%. Or 100%, and at 91% indicated that their members do not always have the devices or technological needs to access telehealth services. Next slide. We are finding that Medicaid health plans are making strides in improving health equity within their organizations, including establishing staff training requirements at 96% and improving their data analytic capabilities at 86%. These are important steps towards building an equitable infrastructure. Next slide. Like last year, we continue to see growth in covered services during pregnancy. For example, nutritional counseling. In 2021, 62% of health plans offered this service. In 2024, that rate increased to 91%. Support from a community health worker in 2021 was 52%. Today, it's 86%. Finally, let's look at lactation counseling and support. Again, in 2021, it was at 52%. And today it is 91%. These are incredible improvements that Medicaid health plans have taken in just 4 years. Next slides. We consistently hear from all Medicaid stakeholders, whether it is a community-based organization or a Medicaid health plan, that there are challenges with accessing data, making it difficult to identify disparities and advance health equity. For instance, half of all health plans reported insufficient data to effectively address disparities. Another 41% indicated that the data they have is incomplete or inconsistent, and almost 20% do not know what data are available. Without reliable data, health plans cannot identify gaps in care, allocate resources appropriately, and assess the true impact of health equity initiatives. Next slide. While nearly all Medicaid health plans participate in value-based initiatives, there's still a long way to go to transition from fee-for-service to value-based. Provider readiness or willingness to participate in the model continues to be a significant barrier, a barrier that we've seen over the past 8 years of the survey. And nearly all health plans reported that staff capacity at provider offices is limited, further impairing adoption of value-based payment models. Next slide. While we know that data is critical to making value-based payment and quality improvement possible, over half of health plans noted that specifically data sharing is a critical barrier to effective adoption of these models. Of the operational barriers cited by health plans, the top barriers were all related to data, including 55% of health plans noting that data sharing and readiness are not always in place, and 55% information technology system preparedness is a persistent barrier. Next slide. It is clear that health plans are invested in value-based payment models, but they still express concern and uncertainty about its impact on quality of care and patient outcomes. For example, as we've noted for years, over half of health plans' value-based payment arrangements with providers are not willing to accept downside risk. This raises doubts about whether value-based payment models will achieve the promised benefits of these models. As you can see towards the bottom of this table, the percentage of health plans reporting that providers participate in downside risk arrangements has remained below 50% and is not expected to increase. Next slide. However, it's truly inspiring to see the breadth of efforts health plans are making to implement value-based payment arrangements, including 68% of health plans using strategies to encourage access to care and 50% providing enhanced payment rates for hard-to-recruit provider types. The findings presented today represent a very small proportion of information that is available, as I shared earlier. We sincerely hope that the survey serves as a jumping-off point for rich, informed discussions among health plans, policymakers, community groups, clinicians, advocacy organizations, and the general public on how we can strengthen and improve Medicaid programming, enhance the lives of Medicaid members, and spur healthcare innovation more broadly. So with that sneak peek of key findings, we want to get some reactions from our esteemed panel of experts. So next slide. I'd like to introduce to you our panelists who will discuss in greater detail their reaction to the survey findings. They've received them in advance and are prepared to share their reflections. You can find more information about them in the link in the chat, but I'll give a quick overview of each before we get started. Hammy is the executive director at the National Academy for State Health Plan, a nonprofit and nonpartisan organization committed to improving the health and well-being of all people across every state. Hammy has worked at the Duke Margolis Center for Health Policy and as the director of the Health Division at the National Governors Association Center for Best Practices. Gail is the director of Mount Lebanon Baptist Church HIV/AIDS Ministry Outreach Services and a commissioner on the Baltimore City HIV Planning Group. Gail is an advocate for community-informed Medicaid improvements that reflect the needs of community members and is currently serving as secretary on IMI's governing board. And last but not least, Wendy is the vice president of government programs for Horizon Blue Cross and Blue Shield of New Jersey. Wendy is accountable for the success and financial viability of the health plan's Medicaid products, among other things. She brings over 20 years of healthcare experience, including as state president at WellCare Health Plans. So we're going to close out the slides now and get started with our panel discussion. So I'm going to pose a couple of initial questions to the panel to start off today's conversation. But again, we encourage those who are attending today's event to please submit your questions via the Zoom Q&A feature. So let's get started. The first question that I have that I want to start with is really, what surprised you about the survey results? Was there anything that you didn't expect to see? Wendy, I'm going to start with you to kick us off with this question.
Yeah, no, absolutely. So welcome everybody. And Jennifer, I look forward to this survey and then the results every year. It's been really, really fun to have been involved. I feel like from the beginning. Um, there's always something in there that you find that's surprising, right? And I think for me this year, um, data and data being a focus wasn't a surprise necessarily to me, right? Obviously, we live and die by our data. Our data should direct what we do. I think the fact that data being now a barrier to success in a couple areas was shocking to me. From a behavioral health integration, the fact that they stated data as a barrier, and I mean this amongst my peers, I think a lot of the Medicaid health plans, sometimes we do this to ourselves. A lot of the plans will have models where they've got behavioral health held in a different company, right? So then you've got two different systems and two different claim systems and two different clinical systems. And I see this model changing over time, but I think right out of the gate, that could absolutely help, a data exchange capability, just working on the same systems. The part about the value-based care, I'll also kind of lay at our own feet as an industry. We have all the data and expecting providers to understand our world and our data and our language. Think about your primary care physician practice. Um, they don't have access to all the different data that we have, right? And it can really start something as simple as, presenting an Excel spreadsheet, right? I know we all want to get to interoperability and kind of all this fancy stuff in healthcare, but I think a lot of our practices just aren't there yet. And I think we could do a better job as an industry at starting with the basics and really explaining things and not expecting a lot of the provider practices to understand right out of the gate what the data means.
Thank you, Wendy. I really appreciate that. As someone who still practices in an FQHC here in DC, it is a challenge for staff to be able to manage the data and understand what it means, and appreciate you adding not only your surprises, but suggestions on how to overcome some of those challenges and barriers. Amy, I'm going to ask you the same question. Anything that surprised you in the survey findings?
Great. Hi, everyone. Well, great to be here, and thank you for including me in this conversation. I love data. I think it really helps inform policy, so I really appreciate this survey that comes out every year that really helps us understand what's happening across health plans. So I'll say that. Just in terms of what surprised me, I'll just start with a couple of things that didn't, because I just felt like I had to say that, and then I'll talk about what did surprise me. The focus on behavioral health, workforce, challenges with unmet social needs, that is so consistent with what we're seeing at the state level. Here at NASHB, we work with all 50 states, and we really try to help them advance in their policy making to improve health. And it's so consistent that it was almost reassuring when I looked through that to see, like, okay, the states are sort of having these challenges, and so are the health plans. And so how can we work together more effectively? What surprised me was, I guess, similar to Wendy, was on the data piece, because when we have conversations with state leaders, they are challenged by data. They are overwhelmed by the amount of data they have, including from health plans and other sources. They don't have the internal data analytics expertise to really figure out what to do with some of that data, and then how to kind of figure out policy. Obviously, there's differences between states. I'm being sort of very general when I say this. So to see on a health plan survey that they too are having challenges with data, I was like, oh gosh, like we really need to figure something out in terms of like working with one another and across agencies about how we can really think about using data more effectively. So that was something I really noticed. And that was across like substance use disorder, MLTSS, social determinants of health. And as we think about like, more integration and thinking about like, whole person care, you need to have all those different data sources. So we're really gonna have to figure that out, both at the state level, the plan level, and frankly, at the consumer level as well. On the VBP piece, I have to say the one thing that I guess shouldn't have surprised me, but that did, that 100% said provider readiness and willingness was a barrier, and that is unchanged from 2017. So we have had many years of experience with value-based purchasing. I think based on all of the information you have in your survey, it's very clear there's a lot of different definitions of what value-based purchasing is. And from a state level, they too are struggling with like, what is meaningful? What is changing the outcomes? What is really trying to move forward on health equity? And so to see that maybe okay, understanding we're all in the same place, but also a little bit discouraging, honestly, to see that health plans have sort of similar challenges with really figuring out how to help providers move forward on this. So part of me thinks like, do we need to think about simplifying? How do we think about really making things easier for the providers as we also struggle with workforce at the same time? And then the last thing I will say, that I was surprised not to see more in this was about budgets, because it's certainly coming up in our state conversations, and specifically around some of the uncertainty with enrollment numbers coming out of Medicaid unwind. Because that's impacting, at least right now, understanding, okay, is the capitation rate, is it appropriate? How are the providers sort of addressing sort of the differences in coverage? And so that didn't really come through on this survey. So, but that's certainly something that's coming up in our conversations with states.
Yeah, appreciate that, Amy. Thank you. Gail, same question.
Well, thanks for having me back again. I had the easier job last year being the host, so I get to ask questions, but now you're asking me questions. What I was surprised about, let me start with what I wasn't surprised about, and that was the shortage of behavioral health providers. In Baltimore, personally, I've seen where there's only one behavioral provider for school, and the school is huge, and they're not even there all day. And they're not, not consistently each week either. So I know that's a problem because, like I said, there's a waiting list of children to be seen by a provider. What I was surprised about was the telehealth as being a part of the solution. That's great, but what if your provider has stopped doing that because COVID is over? So that's something that I was surprised to see. And then the other thing was the data sharing challenges. Here in Baltimore, we have 3 hospitals that are connected. And so wherever, if something happens to me and I'm in the vicinity of either one, they can pull up my information. And, they have something called My Portfolio. So even I can see my information and pull it up myself when if I go to a different doctor or something like that. So to see the challenges there is really surprising for me.
That's really interesting because as a consumer, you're not seeing the challenges and barriers or experiencing them that others behind the scenes are grappling with, the health plans, the states, and community-based organizations and providers. So thank you for providing that lens and perspective, Gail. It does mean that despite the challenges and barriers, folks are doing a great job in making sure that your needs are being met and those in the community, and that information is being shared and you feel like that's seamless. Let's move on to another question here. Amy, you're the leader of a nationwide policy organization. I have a really unique vantage point. We've talked about data sharing, workforce, behavioral physical health integration, telehealth. And I'm not encouraging that you have to go in this direction, but maybe talk about what specific policy changes within Medicaid broadly, or maybe specific to some of the topics that have already come up, that you feel are necessary to make progress towards health equity, and how these changes address barriers to healthcare quality for communities across the country.
Yeah, no, it's a great question, and one that's really important to the conversation. So a couple of areas that I think link to the survey results that we see here, but also that we are hearing directly from states. One is we clearly have significant disparities across states, and that's in different ways. And it's how to understand how to address those disparities through different strategies, because every state is going to approach it differently in terms of how they're going to try to address the issue. So there's access to services, and states have been spending a lot of time, as our plans, it looks like, based on the survey results, of thinking about how do you improve the access to services for things like mental health and substance use disorder. Clearly a huge need, always has been, even more so coming out of the pandemic. And what are the things that are going to change the trajectory of that? And I'll just say from our state lens, because I know less about exactly what the health plans are doing, but from the state lens, there's investments being made. We saw, increases in provider rates. We see really an interest in thinking about more integration. How do you support primary care practices to think more about behavioral health? How do you partner with certified community behavioral health centers and the community health centers out in the neighborhoods to really understand how to expand that behavioral health access? How do we provide SUD services more readily using opioid settlement dollars? I mean, there's a lot of different things happening to try to think about opening the doors. And I think that's really important because when you look at overall, there's, some good news that the overdose rates are not going up, in fact, are going down. But when you parse through that information, state by state, county by county, city by city, you really continue to see significant increases in populations. And that includes Black populations and American Indian, Native American populations. And so the states we're working with are really just focusing on where are we still not making progress and how do we make a difference? And that's going to have a lot of different pieces to it, which includes expanding access. As part of that, it's like, how do we build more trust in our healthcare system? And really in wanting to reduce stigma and going to get the care they need. And that's certainly something that is happening across states in terms of how to do that. And you see that with more partnerships with community-based providers in certain states. And I think managed care plans play an integral role, a really important role in their partnerships with community-based providers and working with states to try to strengthen that. And there's challenges with that, there's funding, there's infrastructure, there's the complications of the Medicaid program where some of those providers do not want to be, directly paid by Medicaid. It's very complicated. So how do we think about building up a stronger community infrastructure, understanding at the same time that, when we put it through Medicaid, we make it more complicated. And then I'll say the third piece, which I think has been really interesting to see, it's focusing on different types of populations. So we've really seen sort of an interest in incarcerated populations. Many states are really looking to expand Medicaid coverage for the populations before they're released from prisons. And that's been really, I think it's 26 states now. Half of those have been approved and half of those are waiting, red, blue, purple. And that's a question of how do you then partner with the health system and the jails and prisons to figure out how to more seamlessly provide coverage to that group, which is not a simple thing to do. It sounds great, but then in implementation, it gets more complicated. And I might just say one more thing, and then I'll stop, is just going back to workforce and how you address disparities in those workforce challenges. It's been interesting to see at the state level, the expansion of Medicaid coverage for, community health workers, doulas, midwives, peer supports. I think that's, and it's reflected in the plan results too, thinking about how we expand the workforce, traditional healthcare workers, but also the supplement and the expanded care team. And I think the success for those programs is how do we truly embed those providers in the system of care that we have. They can't alone solve, these sort of big challenges, but helping them kind of integrate into the system and really supporting them, not just with Medicaid reimbursement, but also with all the other pieces to be successful, I think is going to be key.
That's a lot, Amy. I think that's going to be an incredible list of things that we all want to achieve. And I'm curious if Wendy or Gail have any reaction to some of these pieces. But Wendy, I'm specifically thinking of you and the workforce and the workforce efforts that you have been leading in New Jersey. And if you wanted to respond or share a little bit about how you're thinking about what Amy just said and expanding that workforce.
Yeah, no, there was a lot there. All spot on. I think the challenge, and this came out in the survey somewhat in relation specifically to behavioral health, but I think depending on where you live in the country, you're feeling this to different degrees. But I worry we're really at the edge of a cliff here when it comes to provider access and availability, just based on sheer numbers, right? You look at the average age of physicians. I know there was a note in the results about behavioral health access maybe being related to rates. And I can tell you, here in New Jersey is not a low density state. Finding behavioral health providers that take anything but just self-pay, i.e. cash, is difficult, more or less Medicaid. And I think it's going to take all of us really working together. And I think some states work better in more partnership. And I think even at the federal level with managed care organizations, right? We can't get into this adversarial, finger pointing about, their access and not enough this or bad data in directories, right? It always goes back to data. I really think that we as a larger community have to figure out ways to increase the supply of providers, just based on pure demographics, right? I think New Jersey's been almost cutting edge. I don't want to give them too much credit here, but we really have done a lot in improving access to alternative care, midwives, doulas, community health workers. And I think you do need these extenders, right? And I don't think you're seeing the barriers that maybe we saw even 10 years ago with the physician community about kind of being anti, nurse practitioners, right? I'm going to date myself. But remember when nurse practitioners first became a thing, right? And I think we're past that because I think there's an understanding that we as a country have to really all work together and be creative to shore up access, because it's not just about money, it's literally about people at this point.
Thank you, Wendy. That's such a good point. Gail, did you want to add?
I just wanted to say, and also reaching out to some of the colleges, because we can get, as they graduate or as they get to the intern state, it'd be great to have them a part of the system so they can see how everything is working. And then that will increase the amount of behavioral providers. I just don't think they're, reaching out to the local colleges, the HBCUs, because it makes a difference when you have providers that look like you, talk to you about what you're going through, especially if they're coming from the area you live in. So I think if that's addressed or if that could be helped, that would be great.
Really demonstrates that a lot of the issues or the root causes of some of the challenges that we experience in Medicaid are multi-pronged, and they're not just healthcare, but they're total care, total life, social determinants of health, and even beyond that. And when we're talking about education and the educational system and how they train and prepare the next generation, making sure that it does look like the community that they're going to serve and what investments they're making. So to Wendy's point, and also Hammy thinking broadly about across all these different topics, that it does take all of us, and it takes multiple systems working together, and we can't work in isolation. So thank you for making that point, Gail, and the panel around this topic. Wendy, I'm going to go back to you. You mentioned nurses, and you are a nurse and a managed care leader. And over the years that I have worked with you, I know that you are impassioned and committed to the members for Medicaid. And that's partly why we always invite you back to this panel, because you are centered on community, you are centered on the lives of people enrolled in the program. What I'd love to do, knowing your expertise in MLTSS, and that's managed long-term services and supports, I'd love to know what you think about how does Medicaid MLTSS program address unique needs for individuals with complex health conditions, and what can health plans do to enhance patient outcomes in this space?
I always say MLTSS is the holy grail of care management, because it really is. So I think it's your most vulnerable, right? Your most vulnerable population for a wide variety of reasons. And I think it's the ultimate in care management. MLTSS programs, I mean, obviously there's a component where there's folks that are possibly institutionalized, right? Long-term care residents. And I don't want to discount that part of the program because that's vitally important. There's a lot of amazing work that's done where care managers can spend 6 months to a year to get somebody back out of an institution. I mean, can you imagine, right? Like, what it takes to get somebody who's been placed in a long-term care facility back out into the community with the supports they need. That's tremendous. And then the other piece of the program really is that, what can we do? What wraparound services can you have embedded in these programs to keep people to their best health and living in the community or living in the least restrictive environment they want? I talk sometimes when social determinants first became a buzzword, I kind of rolled my eyes sometimes, and I was like, in Medicaid, we've been doing this forever. We didn't even have a word for it. We just did it. And I think when I look at MLTSS, right, from a care management standpoint, when you hear people talk about member-centric, put the member in the middle, wraparound services, MLTSS programs have been doing this since the beginning, right? If somebody needs a ramp, you build a ramp. If somebody needed an air conditioner, right, for air purification, you put that in. They needed a new refrigerator, right? I mean, so there was a full understanding that anything the member really needed, really, I think 90% of what goes on in our world can be tied back to health. And MLTSS programs have been amazing by the states that have embraced them because they allow plans the flexibility, right? CMS grants waivers to allow flexibility to really do things outside of traditional medical care. I think what's exciting is I think you're seeing the model start to bleed into the Medicaid program at large. When you look at things like some of the other payments for community health workers, social supports, if we have any time, like, the expansion of housing support services, so stuff we've always done in MLTSS, which is why it's just the most amazing program in the world. Is now starting to kind of bleed out a little bit into Medicaid. And I know there's scale issues and funding issues, right? But it's super, super exciting from my point of view, because it really is, I think, one of the most amazing programs. And yes, Jennifer knows I gush over it every time I talk about it.
Thank you, Wendy. I mean, I would love to dig deeper on what you just said, but my colleagues are sending me all these questions that are coming from the audience, and we do want to pivot to make sure we can get as many of those in. So I'm going to start with this question here. It's related to doulas. Doulas is always a hot topic every year when we have the survey release event. And this year we received a question from a participant in this release event who noticed that there was a decrease of doula support from 2023 to 2024. Amy, I'm going to punt this question to you. In your perspective, looking at all of the states, do you have any thoughts on what might be attributed to this decrease? What might be happening in states around their support or decreasing support of doula services?
Yeah, I saw that, and that was interesting because we continue to talk to states about doulas and expanding Medicaid coverage. So there was two things I thought of when I saw that. One is we have heard that there has been some blending across community health workers and doulas, and that some folks are opting to have the community health worker category. It's a broader role. I don't know if that's attributable to what you're seeing in your data, but we're certainly talking to states about that, about how the lines are being blurred there. And people are using multiple roles. So don't know if that's attributable. The second piece is we did talk to a couple of states that said, we set up the Medicaid benefit and it was hard to get the folks to come. So it was just hard to recruit based on definition, based on how they were rolling out the program. And so there was more work that needed to be done to really engage the community. And there's a couple of states that have been, really successful at that. California, Virginia, I could name others. New Jersey is actually one that's done well with that. But I don't know if that contributes to just, states maybe because if they don't see the uptake, they're pulling back a little bit on it. I don't know. I don't know exactly what happened at the plan level in the reporting, but that's certainly something that we've heard as well.
Thanks, Amy. Gail, on the ground, I know that you're very connected in the community in this topic in Baltimore, and what are your thoughts
about the doulas? Or
what are you seeing?
well, I can tell you one thing. A lot of people don't know about the benefit. They don't know about the benefits. We have to educate them about Medicaid and what's offered. And the fact that that's something that's really is taken on, taken height. It's really not in Baltimore because we've run into a lot of people who are illiterate. They don't read the books that tell you about, managed care or anything like that. A lot of them don't even go to the hospital unless it's an emergency. So yeah, that's an issue.
Thank you. Wendy, you want to jump in or should we go to the next?
Yeah, real quick, I would just offer, and again, I shout out to, my industry and for state leaders to ask some of these questions where we've run into barriers, and I think we've done a good job of trying to knock them down, is a lot of the doulas, like a credentialing application to a doula, we're handing them a physician credentialing application, and it's 27 pages. It's got words in there that are not applicable, but there's no NA box to check. I think it's a challenge, and I think the whole concept of compliant claims billing and all the things we have to do in the government programs world. I think a lot of the doulas, unfortunately, unless there's really a lot of hand over hand support, especially in the beginning, get frustrated and say, the juice isn't worth the squeeze. So I think we need to do a better job of kind of supporting, and I would ask, fellow states to say, you're not getting the traction, dig a couple layers deeper and find out, because I think they want to be in this space, but if it becomes too difficult, then I think they get discouraged.
So sort of like needing to invest in the infrastructure to support doulas to be able to really thrive in their states. I'd be remiss if I didn't put a plug in here. IMI has our National Doula Learning Collaborative, which just launched. And we will certainly be sharing learnings from that activity across the US and 7 different states. So stay tuned for that information to help guide states and folks on the ground who are trying to figure this out. It's new and innovative, and that it means that there's going to be challenges. And instead of giving up, I think we have to dig in and figure out how to find those solutions. And I believe that we can. So really excited to see this continue forward. Another question that we received was sort of a preface of, we know some of the barriers are longstanding, such as transportation or language access. What are the promising models that tackle these challenges? Wendy, can I start with you?
Yeah, no, absolutely. And I think it's community-based providers, right? It's the folks that are embedded and local to the communities. A health plan can do so much, right? But I think it's really going to be community by community, area by area. Candidly, that's why I fell in love with the Medicaid program, because it's different in every state. It's different in every community, because we're different in every state and every community. And the needs are. And I really think our community-based providers are key to breaking down some of those barriers and figuring out the solutions.
Yeah, community-based is the answer. We saw that during the pandemic. Community-based organizations and providers became the connector, the glue, the primary support and foundation. Gail, any thoughts on Wendy's comments about the community?
I agree 100% with Wendy regarding that, because community-based organizations will provide lists. They will provide Ubers if you need it. They'll provide tokens for you to get there. Whatever you need. So it's no reason for you to miss an appointment if you have an appointment. They will help you get there. And if it's a language barrier, then they do have providers that can help, that can step in and help with speaking to patients. So community-based organizations have done wonderful jobs.
Thank you. Let's move on to another topic. In the pharmacy fact sheet, it says that single preferred drug list, PDLs, are challenges to Medicaid health plans experience when managing the pharmacy benefit. Amy, can you share more about anything about what the challenges might be associated with that? And then I'll hand it over to Wendy to give her thoughts.
So I can certainly talk from the state perspective, and then I'd be curious what Wendy can share from the plan perspective. So from a state perspective, I think there's some real momentum around how do we better understand drug costs, and how do we ensure that there's more uniformity across the experience of drug purchasing and the consumer on the other end of the receipt of the pharmaceutical. So one is there's some states that are carving out drugs from their managed care programs, and some of that has to do with Medicaid rebates on drugs. So it's not just about the consumer, and it's also about the payment. That's certainly happening. And then there's other states that are like, well, we don't want to carve it out, but we want to have more uniformity of cross-plan coverage of drugs. And that's why then there's this single formulary that makes it easier from a state perspective to understand how the drugs are being covered across plans. And frankly, there's also uniformity across how they're how the rebates are being collected. So it's a two-prong piece to it. And I really, I don't feel I can appropriately comment on some from a plan perspective, why that's a challenge. So I would really kick it to Wendy to share that perspective.
See me, Wendy?
We will run out of time if I even try to go down this road. I think the positive thing about our country, right, is that we really have an amazing pharmaceutical industry that's done life-saving drugs is just huge. I think we also have one of the most complicated, I won't say convoluted, but I did funding systems when it comes to pharmaceuticals. I think the challenge for Medicaid plans is obviously our industry as a whole does not wish to have drugs carved out to a state. I appreciate the state rebate. I think states that have gone down that path are not finding the savings that they thought they found, but obviously, you know, I'm sure I've got a biased point of view. But I would say that I think having integrated care is always the best care. So if you put aside the financing piece of it, I think, you know, having pharmaceuticals pulled away from your overall care coverage is probably not the best idea. But I will admit my full bias and just put it out there.
All right. Thank you, Wendy. We appreciate that. And I apologize. There are probably a dozen more questions from the audience that we're simply not going to be able to get to because we are running out of time. And I do want to take the moderator prerogative to ask the final question. So before we close, my final question for the group, and I have to give credit to Wendy because she's the one who created this question when we first did our first release event on Zoom. And I love it. And it's the best way to close out a panel, in my opinion. So thank you, Wendy. The question is, if you had a magic crystal ball to predict the future, what do you think will be elevated in the report next year? For instance, what issues will take center stage over the coming year? What trends, issues, and developments do you think we'll be talking about? What, just generally, what is coming our way, positive or negative? Gail, I'm going to start with you.
I think the focus will still be on child behavioral health because that's something that's affecting our community at a big level, and the fact that we don't have enough providers is making a big difference. So I think that would be one of the things that would take center stage next year.
Thanks, Gail. Wendy?
The continued expansion of paying for social determinant types programs in the Medicaid space. I think we're going to see a lot of expansion of housing. I think somebody had mentioned it before, the early release programs, right? I think there's actually some bipartisan support for programs like that. So I think we're going to see some expansion for reentry programs. And as I alluded to before, I think the larger Medicaid program is that some of those really amazing things in the MLTSS space are permeating the larger program.
Mm-hmm. That's exciting. Hammy, close us out.
Okay, well, they took a lot of my topics, so I guess I would agree. I do think I'm going to just say workforce, though. I really do think under all of these challenges is sort of we need more workforce across to address children's behavioral health, to address adult mental health and substance use disorder, to address long-term services and supports. People want to be at home. They want to get services at home. We don't have enough providers there. And I also think across some of the social determinants piece and really finding the community-based providers to partner with that. So workforce at large, I think, will continue to show up in that survey. I do think on the track that states are on, we'll continue to see investments in social determinants of health and thinking about how we address some of the other challenges around aging. What I'm really curious to see is, and you know, we don't need to get into this, we don't have enough time, but there is a change in administration and a change at the federal level that is very significant. I also, because I work at the state level, I'm very focused on state budgets. So 2025, there's some uncertainty. I think there'll be more uncertainty in 2026 about state budgets, but there is predicted to be less state tax revenue, and some of the federal dollars that have allowed states to make all these investments in behavioral health and aging and SDOH, like the expansion part of Medicaid, those dollars will no longer be available. Come the end of 2025, going into 2026. So how does that impact what the state policy agenda will be able to support in 2025, but I think probably even more so in 2026. And then how does that then, impact how the plans are approaching the work? So that I think is something to watch for. I'm a glass half full person. I think there's so much good work to be done. I think states and plans really want to make a difference and improve health. So the work will continue, but there are these, I think, additional factors that we haven't had the past couple of years with respect to budget and policy change. So
I would love a whole series of webinars just on this topic. So maybe we'll be inviting this group back to dig into that one a little bit deeper, because money drives a lot of this work, and we have to have the resources in order to have the impact that we want to have. So thank you for that final thought, and thank you to our entire panelists. I really appreciate your thoughtfulness and your vision on these important topics, and really making this event, as always, a special event that grounds the data in the community, grounds the data at the state, and grounds the data at the health plan perspective, which is really important. At this time, we are putting a link in the chat for a very brief 2-minute feedback survey. We use this information to improve our webinar offerings and experiences. It's really important to hear from you so that we can continue to meet the needs of our Medicaid community, including topics. Please let us know what topics you'd love to hear from us for webinars or resources. Please use the final minutes of this webinar to complete it. As we begin to close out today's release event, we want to thank our esteemed panelists again, but also the Medicaid health plans who took the time to complete the annual survey. It is an enormous survey. It is, I'm going to guess, 45 pages at this point. It takes a lot of work, and we appreciate every health plan and their commitment to complete this survey year after year. As with our panelists, our health plans are leading policy efforts, launching innovative initiatives, and advancing health for the benefit of all Americans, and we love being able to capture that through the survey. We also want to thank the Robert Wood Johnson Foundation for its generous 7-year support of this critical work, which led to such a robust conversation. And imagine taking this information and using it to inform and guide policy and other components and places. We also want to thank our National Advisory Committee for this project, chaired by Poppy Coleman, who volunteers endless hours ensuring that we produce the best survey instrument and fact sheets with findings that can be used by everyone. And finally, a tremendous amount of work happens behind the scenes under the leadership of Sydney Berry, Anna Bonelli, and Michelle Singh. Without all of you, this wouldn't be possible. So I really want to shout out to the team. And next slide. Finally, I want to let you know that a recording of this webinar will be sent to all registrants of this release event early next week. In the meantime, you can access the survey findings using the link in the chat box and at our new website. Check it out. We're really excited to share with you. It's much easier to navigate. And please give us feedback if you find any issues or challenges. But more importantly, thank you to all of you for joining us today in the discussion of the annual Medicaid MCO survey findings on a Friday afternoon. Your commitment to improving the lives of Medicaid members is critical, no matter what your role is in this work. Thank you to everyone for everything that you do.